Madam. Good evening, Abha madam.
Yes, sir. Mehul here.
Mehul is here. Good evening, Carmen. Dr.
evening.
Carmen, how are you? This is our second time meeting here from you, and it's a great pleasure always to hear you regarding the newer ventures. And we have with very senior doctor from Gangaram, Dr. Abha Majmudar is also there, right? So as an expert, that after the your speech, then we can have a certain interaction and his review regarding that what we are at present, what is the current scenario in India. I think so, Mehul, we good to go.
Yes, sir. So we are live now. So we will start.
I think so. 1 minute. मेरा लेक्चर तुझे वो करना है बेटा. मैं तुझे बताऊंगा उसी तरह से करना पड़ेगा.
Okay. So good evening, all faculties and delegates. So first of all, I Mehul Doradia on the behalf of Corona Remedies Private Limited. I welcome you all in our live webinar Core Connect. So this is the global perspective in ART, which is initiated by the Wings Women Hospital and associated with the IFS, Indian Fertility Society. And in this today's webinar, which is on the basis of our theme, the selection of MRIV. And we have two expert speakers. One is Dr. Jayesh Amin and our international speaker, Dr. Carmen Rubio. So first of all, I welcome Dr. Smriti Sparsh, who is our MOC of this webinar.
Smriti, you can start. I think so. You can take the mic.
Yeah, I'll start. Okay. Thank you so much. Thank you, Mehulji, for a warm introduction. Very good evening to all respected seniors, friends, ladies and gentlemen. As we begin the session, I would begin with a very small quote by Sir Rabindranath Tagore that said, "You can't cross the sea merely by standing and staring at the water." One such contribution has been by the specialists and the gynecologists now, who that have learned over past so many years have been imparting their knowledge through such wonderful platforms, through the webinars and the CMEs. Indian Fertility Society definitely has introduced such platforms and interactions amongst the professionals for sharing of the knowledge and also keeping up with the vast advancements in the field of infertility practices. Where there has been such a wide visionary and legacy of contributions by so many people who have been there actively in the fertility society, but taking an opportunity to introduce one such path-breaking contributors have been our respected president of IFS, Dr. K.D. Nair sir, Honorable Secretary IFS, Dr. Surveen Guma madam, our dear and respected Dr. Jayesh Amin sir, Additional Joint Secretary IFS, Madam Dr. Kokila Desai, Secretary IFS and Gujarat Chapter. It is a very interesting session today with series and two speakers, and there is an expert in the session today. I would also like to take an opportunity to introduce our very special person and very dear person to me, Dr. Abha Majumdar Madam, the expert for the series today. Madam is the Director and Head of IVF and Human Reproduction, Department of Obstetrics and Gynecology, Sir Gangaram Hospital, New Delhi. Was also the part of the team of doctors that were responsible for the first IVF baby born in 1991, the first frozen oocyte baby born in Jan 2009 of the Northern India. With having so many achievements and awards to Madam's name, to name a few would be the President's Medal for the Best Medical Graduate, Dr. B.C. Roy's Award for Outstanding Contribution towards Medicine and the Field of Specialty, the Vikas Ratan Award 2002 by the National Economic Development and Growth Society, the Chikitsa Ratna Award 2007 by the International Study Circle, Lifetime Medical Excellence Award in Obs and Gynae by the Hippocrates Foundation 2014, the Abul Kalam Gold Medal by the Global Economic Progress and Research Association, awarded as the Best IVF Clinician of India 2022 Also awarded as the icon of IVF of North India and the IVF champion clinician for the year 2019. I welcome you, madam. And just going through our key speakers for today. One such wonderful personality and definitely my mentor and guide, Dr. Jayesh Amin sir, who is the clinical director of the Wings IVF group, also the additional joint secretary of the Indian Fertility Society. Sir has also numerous achievements, and I will just take a moment to mention the few, which is definitely a proud moment for me. Dr. Jayesh Amin is a national and an international faculty at various fertility conferences in India and abroad. Dr. Amin has been awarded as the Times of India IVF icon for the year 2018 and 19, with excellence in the infertility treatments by the then Union Health Minister Sir Shri JP Nadda ji. Fertility Game Changer West 2019 by the Economic Times. And it is now more than 30,000 plus live births through IVF. Sir has had a vast contribution now, and it's been far more years than 8. And too many successful cases, it is definitely more than 8,000, who has been previously had unsuccessful IVF treatments. I welcome you, sir. And our international speaker for the day, for the evening, is again Dr. Carmen Rubio, trained in science in the University of Valencia, Spain. Dr. Rubio specialized in the cytogenetic studies in the human reproduction, partly in the University of Barcelona. She completed her PhD in the field of reproductive genetics, and postdoctoral research included the research in male and female meiosis in the laboratory of Drs. Patricia Hunt and Terry Hasselt in Washington State University, USA. Has published more than 100 papers in the main peer-reviewed specialist journals in the field, books and chapters, as well as numerous lectures at conferences worldwide. Currently, she's also the Vice President R&D Genetic Services at Igenomics. I welcome you, Dr. Carmen Rubio. And I would just request our expert for the day, Dr. Abha Majumdar, madam, to just say a few words, give her welcome address. Thank you, madam.
Thank you, Smriti, for the kind introduction and having the ceremony opened. I only want to open the ceremony by one little thought, that a Pandora's box was opened in 1978 with the birth of Louis Brown. And this was the biggest revolution which could have happened in the world of IVF. Ever since then, if you look at the difficulties which people face then to have the first IVF baby, no hormones, no ultrasound, there was nothing they could do, no laparoscope, no vaginal probes, nothing. And they still created a baby. We are now so advanced. We have so much of equipment, and yet we keep on developing every day new methods. The whole aim is to bring IVF to such a stage where it becomes very easy for a woman to get pregnant, to reduce the dropout rates, reduce the negative pregnancy rates. And for that, we have been working strides. When we make embryos, we first try to see morphologically how good they are. Then as evolution went up, the time lapse came in, and we also looked at the developmental rate. Then came in the pre-implantation genetic testing. And in that testing, we started looking for aneuploidy. But then we thought, why should we hurt the embryo? Then is coming up the non-invasive genetic testing of embryo. So we are moving from morphological selection, which is the basis of embryo selection, to now non-invasive genetic testing. And I think this whole journey will be covered by two eminent speakers, Jayesh and Carmen Rubio. So I welcome them on the dais, and I open the forum for them to start their distribute or sort of share their knowledge on these two topics with all of us.
Thank you, madam. Thank you, madam. I would request Dr. Jayesh Amin, sir. Sir would be the first speaker for the evening. And sir, the floor is all yours.
Smriti, just I'm sharing my slide. So
Yes.
Is there a problem in starting the slides? Someone can help Jayesh? Someone else can open the slides for Jayesh?
Ma'am, I think the slides are only there. Mehul ji, do you have the slides with you?
No, ma'am, I don't have this slide.
Then Jayesh, you can send your slides to the organizers and they can project your slides. Jayesh, can you hear us? Jayesh, can you hear us?
Sir, please unmute.
You can send your slides to Smriti or the organizers and they can project if you are having difficulty.
Unmute करिए sir.
Hello,
हो गया.
hello.
Yes, yes, sir.
Yes, am I audible? My slide is also.
The slides are not visible yet, sir.
Yes, somebody is working. Now
Okay,
slide
sir.
is visible.
No.
No, sir.
This is PDF file, sir, we are seeing.
नहीं बेटा वो री करना वो PDF फाइल दिख रही है
Slide open किया है sir.
लेकिन PDF फाइल दिख रही है अभी
PDF is there, sir.
ये
Non visible. PDF बंद कर दूं?
हाँ बंद कर दे हाँ बंद कर दे वो
फिर बंद हो गया.
नाउ शेयर करो
Screen
screen.
sharing है.
Now it is visible,
sir.
everybody?
Yes, sir. Visible, sir.
Okay, fine. Okay. Sorry for, so I'm just starting fast. Okay. So sorry for my all technical, which was the today's talk is basically we are talking on the embryo selection technique. And thank you so much, IFS. Thank you so much, Abha ma'am, to accept my invitation as expert. Thank you so much, Carmen Rubio, doctor, for accept and giving the time in today's busy scenario. So let's say something what Dr. Abha madam is telling about the first baby which was born in 1978. And we know that lot of trial, after a lot of 13 trial, we have our first baby which was born in 1978. And look at the journey of the IVF from 1978. Then we can have a adding of oral drug, then followed by HMG and followed by recombinant FSH. And then we have a something moving toward to prevent the OHSS. Then we have a OHSS free scenario where we can have a launching of the antagonist, a patient-friendly environment, and after that to make all the OHSS free clinic at present. I think so we all people are thinking about a freeze all. But what is basically we want a higher success rate. And when we are talking about the higher success rate, and as rightly says that when we are opening the black box of the implantations, and as we know that for implantation that 85% or 75 to 85%, the responsible is embryo. And today's basically, we are much more discussing that how we can open and how we can open the black box of the embryo and what are the techniques which are available. And that is what I am saying that when we say something about live birth rate, these are the multiple factors. It's not only embryo, it's implantations, it's all about the endometrium, it's about the microbiota, it's all about the immunology, it's all about the other science like HLA, lot of science which was involved. And lastly, I think so we are all people are working on the crosstalk between the embryo and the endometrium. So these are the all factors. Beside these factors, today's we are more discussing on the embryo. And when we see something embryo, these are something 1 to 30 plus embryo per IVF cycle. So more than 15,000 embryo per year cycles will be there in the USA. And where all people are using most of the people are using morphologically. At the end of the day, they want to select a single embryo transfer, select a one morphologically based embryo. And to go that, what we are basically thinking, we are thinking that let's have a certain, this is a factory, let's put something, some factors, some filters in between from creation to selections, and making a best cookie and getting the best manufacturing at the end of the day to give a best success rate. And the other part about the basic intention, that why we are much more focused, is not only success, but we are focusing on the single pregnancy. We want to transfer the single embryo, and we want to get the higher success rate and reducing the twin complications. So this is, I think, so future is single embryo transfers and higher success rate, and where we need a more specific meticulous selection technique. So what are the personalized decision in the IVF cycle? So how the people are always asking that where I am, can I have a baby? Their first question. What are my chances? Their affordability, which treatment plan they can choose, how many embryo, and that is here we are coming, how many embryo. And when we are talking about the embryo, I already say that we want to move, we want to counsel in the Indian scenario now, in the tomorrow India, where we want to transfer a single embryo transfers to prevent the multiple. And for that, I think so morphological screening is more important. So there are three screening is there, two screening will be that there is a morphological screening of the embryo and genetic screening of the embryo. I will be more discussing about the morphological screening of the embryo. But before that, the debate which was open here, that instead of a lot of publications, and this is the STAR trial compared with the SART pregnancy outcome, and they said that whether the age between 25 to 34 years or 35 to 40, the most single embryo transfers, success rate will be the same. So it is around 50%. It is only increase when there is advanced maternal age. So we need to understand what is the role of morphological factors and the genetical factors. So we are practically discussing of this whole scenario for a non-invasive technique for single embryo transfers and to prevent the multiple pregnancy. So what is embryo grading? Embryo grading is a method used to for the every embryo transfers, and that is that how after we are doing and injecting the sperm inside the egg, and these are the things that embryo means what is exactly grading out of this embryo when we are using this time-lapse technique. We know that after day 2, 48 hours to 72 hours, there is a genome which is activated, that is maternal and paternal. Before that, maternal genome is activated. These are the different factors which is responsible for the embryo development. And these are the different stages of the embryo that we can say day 0 to day 5 by the microscopic examinations. We can divide that this is 24 hours, this is 48 hours, this is 72 hours embryo, day 3 embryo, day 4, and the blastocyst and the hatching embryo. How we are going to assess? And we are having a 3 non-invasive technique. That is what I want to say. And these are the different technique which was developed in the past year. That is a microscopic, the picture technique that we are always using in our clinic. Still, most of the clinic are always using the morphological science. And beyond that, the morphological science, we do have a today's era is a time-lapse technology, the TLM classifications that. And beyond TLM, should we end with the TLM? But because there is annotations all by the human beings, let's say something humans are always putting their interventions when there is an intra-observer variations. To prevent that intra-observer variations, we are now shifting our whole scenario toward the artificial intelligence. And I know that genetic screening, what will be the future, that I think so will be discussed by the Carbon Review. But today I'm going to more discuss about the non-invasive method And when I talk about the non-invasive method, it is more about the morphology, morphokinetic, and time-lapse imaging. All these three including, and another part is the recent, which was published, and people are working on that. There is no randomized control trial, but we can say that it is artificial intelligence selection of the embryo. These are the timing of the embryo scoring. I think so. We all people are knowing that about the 2-cell, 3-cell, 4-cell, and 5-cell. So it is around the plus or minus hours, which is suggesting the normal timing after the insemination of the sperm. And look at the Istanbul Consensus Workshop. What they say is that common criteria and terminology for grading. So let's say something. We start from the day 1 to day 5. How can we grade? I will like to see that. I would like to also elaborate and highlight what are the certain grading which might be are not seeing in our clinical practice, which might have in the future do have a good output. And this is first, it is called day 1 embryo. So this is day 1 embryo, where we can know that the nuclear polar bodies, right? When there is a 2p and 2pb will be there, 2 pronuclear bodies are there, with the 2 polar bodies are there. And what is the situations and symmetrical and the adjustment of that, it will divide the embryo in the different score. And that score is Z1, Z2, Z3, and Z4. The category 1, which is symmetrical. So if they are aligned in the center and symmetrical, or peripheral and symmetrical, then you can say something it is Z1 and Z2. So this is a grade 1, grade 1 we can say symmetrical. But when it is going to be say something about is aligned, but the size is different, but it is a sparse, it's maybe non-aligned and size is same, or maybe they are dispersed with a different size, and these are the same which is called as a non-symmetrical, peripherally located pronuclide, and other arrangement will be there. If they are abnormal, that means if there is 0 or 1 nuclear polar body is pronuclear, then it is called abnormal. So this is what we can say the Z scoring system. Now let me say something. When we are theoretically knowing that what is exactly the clinical importance, which say that in the era of day 5, they said the number of days. So as the embryo grows, these all nullify, and grading of the number on the days, day 3 or day 5, which is having a more important compared to the Z scoring. But look at, I think so in the next part, I can say this Z scoring is important or not, that we will decide according to the time lapse technique observation. But at present, the studies are still saying that the cleavage stage embryo grading and the day 5 grading, which will much more beneficial compared to the Z score. Let's say in the past, when we are transferring a day 3 embryo in a certain cases, what are the grading system, the cleavage stage embryo grading system? It's all about the blastomere. And what about the blastomere? That symmetry, asymmetry, number of the cell, multinucleations, vacuolizations, the spatial distribution of the cell, cytoplasmic abnormalities. And these are the observation that the number of the cells and how we can decide. The Istanbul Consensus, which is met, and they said that grade 1 day 3 embryo, that means all the stage specific cell size, it is about 48 hours embryo, or it is a cleavage stage, so 48 or 72 hours embryo, then we can say that the stage specific cell size should be there, but no multinucleations, and the fragmentation ratio will be less than 10%. If it is 10 to 25%, then it is considered as a grade 2, and if it is more than 25%, then it is considered as severe fragmentations. So these are the different, I think. So I'm showing the grade system, how they are saying multinucleations, vacuolization, asymmetrical cleavage, and the moderate to severe fragmentations will be there. But again, the question arises that should I use this Z score, and can I go for the document, the prediction that can I predict that it will go into day 3, good day 3 embryo? And this is a publication that they are saying that the predicting of the Z score to getting a day 3 good embryo is very poor. So there is no requirement of only one Z score will be effective to predict the day 3 rather than to directly go by the day 3 embryo grading. Saying that this is the same thing that combine is effective, but alone is not effective. So if you say grading of the day 3 and also if you have a grading of the Z score, those both combined is effective in terms of clinical pregnancy rate, but alone is not effective, and especially Z score alone is not effective. Now we will see something. Is there any role of the day 4? That day 4, and as we know that routinely we are not going to see, but the TLM, it is having more important. The time lapse monitoring, it is more important. That what is the timing of the morulations? What is the timing? And that is the most specific paper that I will show you. Apart from the only morphology, it's all about the experience. And these are the different photographs which was saying that the cell which was living after the morula, the compaction, the type of the compactions, it is more important. So it's all about the how your embryologist or how you do have a specific system to record, and then you can give inputs when you want a single embryo transfers. Talking about the blastocyst, and we know that the journey where the gardeners firstly said that the journey where they say that expansion is more important. And the expansion, the more the embryos are associated with the euploid. And after that, they said that no expansion, I will come to the point, but only expansion, I say no, there will be a something role of inner cell mass, and there will be a something role of the tropoectoderm which is surrounding that. So what about the expansion? We all people are knowing that there are 6 expansions, and hatch more the expansions, more the euploid embryo that what we are considering. So embryo should be always more than expansion of 3 if you are having a lagging of the expansions, and it is often associated with the lower implantation rate in a phase cycle transfer. As far as concerned, the ICM, these are the different ICM observations. I think so. Lower size of the ICM is not associated. That is what my practical experience. I will be more focused on the tropoectoderm. But if you are a compacted inner cell mass, then yes. It was says that the compacted, sparse, and the smaller, these are the 3 category where as a clinician, you ask me that I'm a clinician, but I still go and choose my embryo always for my each and every patients, and always getting the experience of the embryologist. And this will give insight me that why my patients are failed. What is the reason? It will give me insight, and it will give me confidence in my counseling when I'm counseling the patients. As far as concerned the tropoectoderm, it is a whole 4-dimensional view. So it's all about the how the surrounding, when you see under the microscope, you will more able to see rather than when you have a 2D picture. Even in the 2D picture, it is all about the continuations of the cell lining, and the more number of the cell which is responsible to explain you that yes, this is the embryo which is considered as a good number, many cells. Yes, that there is a tropoectoderm grading will be there. Now, what exactly should we believe on expansion? Should we believe on inner cell mass? Should we believe on tropoectoderm? And there are a lot of queries are there that what is exactly based. Look at the studies. Then there are some studies which are going that ICM is good predictive. There are 4 studies which is tropoectoderm is good. There is 1 study is that expansion. But let me tell you practically, I do believe that expansion should be looked for first. I do believe in the today's era that if I have a B grade of the inner cell mass, but if I have a A grade of tropoectoderm, that is my clinical sense. But then let's see something what is exactly. And this is the alpha scientist that ICM has suggested as a better predictor of the implantation. And there is a 2013 again publication which says that TE also means that tropoectoderm is often associated with the more miscarriage. So if your tropoectoderm is not good, then the miscarriage rate is higher. The latest publication, which was published in 2022, and which was saying that ICM is the strongest predictor and higher probability of implantations and clinical pregnancy rate. And this is the another more publication which is giving in support about the ICM. Then what about the tropoectoderm? This is a tropoectoderm that they say that predict, are we on the page that we can have a single embryo transfer? And this is where, this is the human reproduction paper. They said, look, it is okay. But they said that it's not only inner cell mass, it's all are important. It's all are carrying something. So you need to choose the embryo where there is expansion, when there is an inner cell mass, and when there is a good tropoectoderm will be there. And this is what they are managing and saying that expansion with a good inner cell mass and a good tropoectoderm. But the question is that, then what is better? A is always better, but I'm saying that AB is better or BA is better. And that is a question, confusion, which was in terms of publication, which was clear by in this fertility sterility. And they says that if the inner cell mass, if it is changed by A to B, but tropoectoderm is changed by B to A, then BA is having the higher implantation compared to AB. And this is the publication which was saying that the tropoectoderm having a higher than the miscarriage rate is drastically reduced. It is also the same thing which was we can consider in the inner cell mass. And look at this publication is that explaining us that BA is better than the AB, where expansion is always in the center, where I believe that expansion is the major sign, because lagging blastocysts I still believe are not good blastocysts. So what is our carry home in some about the morphology? Should we transfer on the morphology basis of the single embryo transfers? And this is the study about the different grading system of number of the embryo and the different grading system. And they say at the end of the day that A is always better and higher expansion. So morphology is associated. It's not like that you can put a bad morphology. Morphology is associated with a single embryo transfers. Do have a higher result. So I will select more morphologically good embryo compared to the bad morphologically good embryo. And lastly, we can say something, this grading and euploid ratios, rates of blastocysts, this is also combinedly says that yes, is euploid. So something we can say that if we have a retrospective data of a 136 number of the cycle, which was gone to the genetic screening, and then retrospectively we analysis that what exactly going about the grading, it was we've seen that when the grade is A, the euploid rateness, see, you can see excellent embryo do have a more euploid, can the good or fair and poor. So poor quality of the embryo, that means the quality of the embryo which is poor, where we can have a more euploidy rate. But the paper which was published that you cannot throw, that I will show you. There are a lot of, because there will be a pregnancy rate which was observed in very minimal pregnancy rate, but there was observed when the patient was transferred with the bad quality of the embryo also. So you cannot throw. There is some success rate which can be observed in the bad quality of the embryo. Going forward, that collapse, if there is a more than 2 collapse, yes, if you have a time-lapse technology, more collapse is associated with the damage of the embryo, and might be it is so. I will like to choose if I am I have a TLM time-lapse technology, and I've seen something more than 2 collapse during its journey, then I will select the less collapse embryo rather than more than 2 collapse embryo. So conclusion is clear at the end of the day, this whole meta-analysis, which is saying that that still there is go far beyond, because still we are not getting a perfect output by the morphological selections, and our counseling is, or our embryo Pandora box of implantation is still not open only by the morphology, where we are just not treating the endometrium. I'm not talking about the endometrium. Then what can I do something beyond morphology? And these are the publication which says that it's not only morphology. Let us move on the morphokinetics and the omics science, which is responsible. And if you see, these are the different score which was given according to the division, the evaluation of the summary of the PN, the alignment of the PN, the lack of the heterogeneity of the granularity of cytoplasm, the 24, 25, 26 hour post-insemination ICSI, then what going on 2-cell timing, the 8-cell timing, the morulation timing, the expansion timing, and they have a certain score, and the more the higher good score, the embryo will be good. That is what we are understanding by this morphokinetics. Saying that, before I will go in the morphokinetics, these are the different before morphokinetics, I think so there are different non-invasive selection technique. It may be oxidation consumptions, pyruvate, glucose, amino acids, SCG, platelet activity factor, which all are not using in our clinical practice. So what we are using in our clinical practice is scoring of the blastocyst stage, morphokinetic, and maybe metabolites. That is what also we are not using. So two more common which was used, it is called scoring and morphokinetics. So is there is still role or place of morphology? I think so. Beyond that, the morphokinetics. Then what about the morphokinetics we are looking for? And these are the studies which was probably what we are looking for is the changes, the timing from conversion from 0 means 1 cell to a blastocyst. So these are the study of the morphokinetics, and they says that which time that you have to more focus, and they say T3 conversion. It may be also direct cleavage, one thing, direct cleavage, multiple pronuclei, they convert into 5 cell to 8 cell, the morulation time, and the morula to blastocyst time. So these are the different time, and they said that let's measure this time. But they launch a manual. So we are using in a kit score. I do have a time-lapse technology of embryoscope, and we are always annotating the embryo with the embryologist help, where we are doing always annotation by the manually. And manually there is lot of difficulty. Is it possible automatic or not? So we are moving on the time lapse, the new era, where I think so that we have to move the all from pronuclei to blastuations, the timing, the direct cleavage, the duration of the cleavage, everything should be measured, and we can exactly see that what exactly important. We can say that these are the different factors controlling the morphokinetics. And I think so S2 is more important, which is convert into T3 to T5. So T3 to T5, and S3 is another more important, that is called T5 to T8, which is the most important parameter of the morphokinetic observation. If this timing is disturbed, this S2 and S3, the normal time which was aligned, if it is less delayed, then yes, these are the slow going embryo which are having a lesser chance for the conversion into blastocyst. And this is what the most important is T8 scoring system, that what we are doing in our previously in our time-lapse monitoring system, that what is exactly time for T5 to T8, 5 cell conversion to 8 cell, it is around, it should be less than around 8.2, 7.8 hour or more than 8.79 hour. And according to that, it was observed, categorized that when there is A and B, if you see something, the blastocyst formation, if the time duration is higher, then blastocyst formation in C and D is very lower, where, so this is called predictions of the blastocyst by T5 to T8 conversion. And the implantation is also depending on the timing, the blastuations, the expandation of the blastuations. If the delaying blastuations, they do have a lesser implantation rate compared to the timing blastuations will be there. So this is the time-lapse parameters with blastocyst predictions and the morulation. So morulation here, I can say something, if the time of the morulation is less than 8 hours, which is more predictive to say that they are having a lesser blastocyst formations and lesser live birth rate, which was observed. So these are the factors what I want to put in the AI. And with the help of this non-invasive automated marker, I can put a single embryo transfers if I do have a good, but then I need some prospective randomized controlled trial. Should it really increase the euploid embryo or not? So I can say that the time-lapse advantage is embryos are not exposed to changes in light, humidity, temperature, pH, gas phase during the development. And embryo with morphokinetic abnormalities may develop into euploid blastocyst. So this is the another thing which was observed, that even though morphokinetic abnormality, the embryo which are showing that euploid, and this is that what abnormal, direct cleavage, rapid cleavage, and the reverse cleavage, and even the prolonged S2. But the most important part, if you see here, what exact in this slide, that overall 111 irregular cleavage was observed, where we can say that when there is a direct cleavage, 1, 2, 3 direct cleavage, the euploid blastocysts are 0. So most important is direct cleavage. So we need to always, we can also not discard, but we can segregate that embryo which is considered as a direct cleavage is there. But there is something that we can work out on this parameter, which is really important for single embryo transfer when we have a too good qualitative blastocyst transfer will be there. The Cochrane data, which is at the end of the day, they say that time lapse, I said time lapse, they said no. A time lapse monitoring still don't have a clear view that it is going to improve and it will give more advantage on the morphological selection parameter. Another double-blind randomized controlled trial investigating a time-lapse algorithm for selecting day 5. That conclusion is that TL selection did not improve. But I'm still not tired. I'm working on hard on non-invasive parameters, because that might be going to reduce the more and more costly treatment. Though I am a pro PGS doctor, I will like to say that I shifted my whole treatment, my talk on non-invasive PGS, that I believe that tomorrow is non-invasive after the better strategizations of the publications. So what we want to say that until and even a good randomized controlled trial for the TLM, because it is confusing, getting more morphokinetic and single embryo, frozen embryo transferred will be the future to say something about, because it's all about the system. The system is important. I will not discuss this PGS. Now, artificial intelligence. So what I want to say that we want to put all this together from this is the model algorithm. We need to make the perfect algorithm, because until now, this all TLM classification, which was done by the manual, I think so that should be a good, this is what I want to say. The RIPRO score, that means the viable embryos, the morphologically normal embryo and genetically normal there will be good correlation. And the highest RIPRO score embryo, which was detected by the AI, which is, we can say something about, it's a deep learning, machine learning, and which will provide more and more good qualitative embryo by the artificial intelligence. And these are the graphically where we can go ahead. These are the graphics that we can select better and better in the fertility. by proving AI in the selection of the embryo. But still, these are the more RCT is required. There are some publication which is saying that AI is improving. This is my, I will show you my own publication, which was published, and for the AI, that AI model for predicting, this is the retrospective data. The important thing is that all publication which was published are retrospective. And we say that if there is a high, then at least 75.8% detections of the euploid embryo will be there retrospectively. So that is what in my clinic, I have given the data of around 400 embryos, and we have around 84.7 the retrospective data. But prospectively, I still have a doubt. I'm going to publish that, but I still have a doubt that prospectively this AI is not working. This is the Life Whisper technology, which was first installed in India at my clinic. And this is my first publication which was saying that is around 75 to 85% sensitivity will be there. It is not around 90%. So this is what about the last publication of the AI. And looking to that, I will conclude that we all people to open the Pandora box of the embryo, the journey which was started from the Z score to day 3 score to day 5, an expansion to tropoectoderm and the morphokinetics to AI, we are looking for a good study to prevent the use of the costly treatment in a certain good prognostic patient for a single embryo transfer. Thank you so much.
Thank you, sir. It has been a very elaborate, a beautiful, but very crisp and clear talk. And I'm sure all of us have been benefited. I have been, and I was really amazed to know, sir, that sometimes B can be better than A. So we have to choose BA over AB. Thank you so much, sir. Moving ahead, I would also request our second speaker, continuing with the wonderful series, Dr. Carmen Rubio. Madam, I would request Aba Majumdar Madam to just address Dr. Carmen Rubio, and if we can begin. Her topic is non-invasive PGS. What is the future?
Hi, everybody. I think you will have to introduce her because you have already introduced her.
I have already introduced, ma'am. Just a slight introduction on the topic.
And it is very interesting. It is very interesting all over the world the way pre-implantation genetic testing for IVF embryos is developing. And even the tropoectoderm biopsy, which takes about 4 to 6 cells away from the tropoectoderm, helps embryo to grow back with full potential. However, even that is hurting our scientists, and we want to stop using that. So we had 2 places from which we could pull out fluid without harming the baby, and it was either the blastocele fluid or the spent culture media analysis. And I think Dr. Carmen is going to talk on one of these 2, possibly the spent culture media, which is developing faster than the blastocele fluid analysis. And we would all be eagerly waiting for her to start her talk and give us an insight into this topic. Thank you very much. Dr. Carmen, we request you to start your talk.
Hello, good night, I think, in India. Thanks a lot for inviting me just to be with you in this event. I'm happy to be with a good team of gynecologists and embryologists to share our experience on this topic. Yeah, I'm going to talk mostly about the analysis of the culture media, of the cell-free DNA in the culture media. We tested some years ago also the content of the blastocelic fluid, but when we had to decide where to direct our investigation, we decided to go to the culture media because this is really non-invasive. And if we do the blastocell aspiration in some way, this is invasive, and we need to puncture the embryo, and the blastocyst is going to collapse. So just to have a fully non-invasive technology, we decided just to move to the culture media. So how this works? I think that most of you are aware now of this technology. The idea is just to keep the embryo growing peacefully in the IVF lab. So the idea is fully non-invasive protocol. in which we know that the embryos, when they are growing in vitro, at least in vitro, we know that they release small fragments of cell-free DNA into the environment, that is the culture media, and that when we have a blastocyst with a good number of cells after more than 100 mitotic divisions, we have enough fragments just to do a proper diagnosis. So the real good timing for media collection is day 6, because before day 6, we can have fragments, but not enough fragments, and these fragments can be confounded with other sources of DNA that can be in the culture media. So you will see along the talk how day 6 is really key. So I will start a little on the first research that we were doing, we done in this topic. We started in 2014, I think, with these first studies. I always say that we were very skeptical, extremely skeptical at the beginning. I was the one thinking that why the embryo is going to release this very precious molecule that is the DNA into the culture media. But the truth is that even in the first publication that we have with my colleague Maria Vera, we observed that there was indeed DNA from the embryo in the culture drop. But the truth is that it was mixed with amounts of DNA from the cumulus cells and also from external contamination. So we identify DNA, we compare the results of the trophectoderm biopsy with the results of the culture media, but only in 30% of the cases we identify that the results were concordant. At this very first experiment, we were doing the media change on day 3, and we were collecting the culture media on day 5. But we were not applying any specific part in the protocol to remove cumulus cells or to clean a little better the embryo. So we were just growing the embryo without any intervention. On day 3, we were doing hatching because the embryos were going to have a biopsy on day 5. And then we changed the media and then we cultured that. And you can see that even with the hatching, no good results were observed and a lot of maternal contamination. We learn a lot in this study because you learn a lot also when you have negative results. So we were trying to see where was the contamination coming from. So in this study, we did also analysis of the origin of the DNA using SNPs and comparing the genetic profile of the culture media with the genetic profile of the cumulus cells of sperm. We wanted to understand why we didn't have concordant results. And we observed contamination due to the polar bodies. So we know that there can be DNA from the polar bodies even on day 5, and we identify by sequencing because in a polar body, we should have the complementary aneuploidy that we have in the biopsy. So we can see here the complementary aneuploidy in this profile in the media, and also polar bodies are always female. So we identify very clearly in this case because the trophectoderm biopsy was male, but in the polar body, we identify a female result because the polar bodies are with one X, and the way in which they appear as haploid cells, they appear as this kind of profiles. Another source of contamination, maternal contamination with cumulus cells, and this is very clear. You can see cases in which the trophectoderm biopsy has a very clear abnormality. This is a trisomy for chromosome 10, but then in the culture media, you observe a normal result. And if it is female, we can suspect that this is from the cumulus cells. It can be also from female embryologists, but the most common source of confusion or discordance is the point with the maternal cell contamination. But we can have also external contamination. It's more rare, but in some labs, this can be really a big issue. So in this case, you have the trophectoderm biopsy that has a very clear abnormality, and then the media is a normal male result. So we know that the cumulus cells are always female, so this should be external. It can be from the environment, from the hood, from the technician doing the aliquots of the culture media, preparing the washing dishes or the culture dishes. So at any step of the protocol, we can incorporate contamination. So this is very key. You will see that there are 2 key points just to have a good results with this technology. And one very important thing is to be aware of the sources of contamination and how to avoid it. So how to improve the results in non-invasive PGTA? First, as I mentioned, to understand how to work in the IVF lab to avoid contamination. Second one, the timing for media collection. This is really key. You will see there are clear evidences how the concentration of DNA increases, and there is a minimum amount of DNA that allows an accurate diagnosis. Culture conditions. We need to understand if there are better culture conditions than others, better incubators, better volumes, just to have the best results. And then at the very end of the process, it's simple, but it's important the way in which you aspirate and collect the culture media from the drop, and to be very careful with the oil. And then if we move to the genetic lab, the NGS protocol is important. It's not just applying the same NGS protocol that we are applying to PGTA. We need to work differently. And very importantly, how we diagnose. When we have a result of NGS, it's not the same if it is from a trophectoren biopsy and if it is from a culture media. We cannot do this. If we look as a culture media with the same eyes as we look as a PGTA, as a trophectoren biopsy, you are going to receive reports saying all the embryos are abnormal. And this is not because the embryos are abnormal, it's because you need to understand how to look at the results of NGS in the culture media. And as I mentioned, it's not just looking with the same eyes as a PGTA person. So this is really, really very important. So let's start by the IVF laboratory. We need to have an area in the IVF laboratory in which you have a very controlled conditions, environmental conditions. So if you can dedicate an area, a hood or an area in a bench, in which you, before starting with every process related in the IVF lab with the non-invasive PGTA, you can clean this area. If you have a hood with UV light, it's perfect, but it's not compulsory. You can work with UV light to sterilize all the material, but it's important to have a space that is properly clean before starting the process. We recommend to use DNA way to clean the surfaces, the lateral parts, and also the pipettes. It's very important also to have new boxes of tips, to open the tips, to have the dishes, plastic dishes. It's good to open a new plastic folder. So this kind of little things is just, I always say, is applying common sense in the IVF lab. So if we are aware that the problems can be from our contamination and the contamination of the culture media, we need to put very easy measures to avoid this. So this is related to the IVF lab. And we know that with this, we can really minimize contamination by having the proper and clean areas. And another important part is just the way in which we enter in the IVF lab. So the team that is working in this non-invasive protocol, we need to be covered as in COVID times. So we need to have the cap, the mask, the gloves, and a surgical gown. It's very important not to have the arms like free, because the cells from the skin really are a source of contamination, because we touch the surfaces and everything when we work in the hood in the IVF lab. So external contamination and the area in which we are working is very important to consider. But then we have the internal contamination, as we mentioned, with the cumulus cells. So if we have cumulus cells, we need to take care and we need to be very careful in how we do the denudation. So we don't need to be very aggressive with the denudation. Just your regular denudation with a thin capillary, but not too thin. And once you finish your regular denudation protocol, an additional step, always an additional step, in which we are going to wash the oocytes in a series of drops to dilute the carryover of cumulus cells in the process. So at the end of a row of drops, we are going to have a cleaner oocyte. Then you can culture, do the ICSI, and you can culture the oocyte excuse me, in regular conditions until day 4. And the key step is day 4. This is very important, and you will see that many other teams are identifying this as a key moment in the protocol. So on day 4, we need to look at the embryos, to remove from the incubator. We need to do the specific washes on this moment. We need to do individual washes of each embryo. We recommend to do it in 6 drops with a clean capillary. And at this point, you can see if there is any remaining cell attached to the zona. In this day, it's very easy to remove any remaining cumulus cell. So just pipette a little the embryo, wash it, and leave the embryo clean in the new culture dish. The new culture dish is going to be the dish in which we are going to have the embryos from day 4 to day 6. And these are the specific moments in which the DNA is going to be the one giving us the best result. And what about the timing for media collection? You know that we have this publication in 2018 saying that our concordance rate is higher on day 5. Sorry, on day 6, 7, 84% concordance compared to day 5 with 63% concordance. But there has been another group saying that day 5 is worse in terms of concordance, and concordance rate is higher on day 6, but also pay very special attention to informativity rate. For example, in this study that was a very mentioned study, the informativity rate on day 5 was 17%, and it was 74%. What is this indicating us? That on day 5, only in few cases, they have enough DNA to do the NGS. However, on day 6, 7, the number of cases in which they have enough DNA was higher. And this is very consistent. On day 5, you are going to have a good number of embryos in which you are not going to have enough DNA. And if there is no DNA on day 5, you can do sequencing and you can have an NGS profile, a result. But this result maybe is from the cumulus cells, from the DNA of the environment. It's not going to be most of the time from the embryos. Or at least half of the time, this DNA that you are analyzing on day 5 is not going to be from the embryo. So this is very important. You can have an NGS result on day 5, yes. But the DNA is not going to be more than 50% of the cases from the embryo. So this is very important. So this is the study that we published regarding the timing for media collection. This study was performed in collaboration with the team of Laura Rienzi and Filippo Ubaldi in Italy. We chose this team to do the study because they were a very good team, but also because they were doing the biopsy in a way in which the hole in the zona pellucida was not performed day 3, was performed just before biopsy. So we wanted to see how the results were in fresh embryos in which no manipulation was done before, because in most of the publications that I have shown you in the previous slide, they were embryos donated for research, frozen, thaw, culture. We wanted to see, okay, let's go to real conditions in the IVF lab as if we wanted to do a real case. Embryos without manipulation. We cultured the embryos, the biopsy was done on day 5 or day 6 according to the policy of the lab and the quality of the embryo. And you can see here how the concordance in this case for us was 63%, double than in our previous study, because in this protocol we were already cleaning the embryos and following the IVF lab protocol. But on day 6, the informativity was much higher and the concordance rate was 84%. And we consider that to achieve an informativity above 90% and a concordance rate above 80% is something that can be extended to any IVF lab working, following the protocol properly. I insist a lot in following the protocol because this is key. If you try to skip steps on the protocol, then this is not gonna work. So what I have comment now or so far is for fresh blastocysts. But the truth is that this is working very nicely for frozen blastocysts. So if you have previously frozen blastocysts that you want to test, this is working very nicely for day 5 and day 6 blastocysts. If you have a day 5 blastocyst, you will need to grow overnight, because if not, the informativity rate is not good. If we have a day 5 blastocyst and you grow like during the day, 6-8 hours, then the informativity rate, as you can see here in the blue bar, is about 50% compared to a trophectomy biopsy on day 5 that we have very good informativity rate. However, with the same day 5 blastocyst, you keep in culture one night, overnight, then you can have an informativity rate exactly the same that the trophectomy biopsy. So it's working very nicely for day 5, culture overnight. And for day 6, however, you can just culture 6 to 8 hours and your informativity rate is going to be very good. And once you have an informative resource in culture media from a frozen blastocyst, you can have very good concordance rates that are around 90%. And I would say that this 90% concordance, when you compare with the inner cell mass, is very similar to the concordance rate also of the trophectomy biopsy with the inner cell mass. So we consider this as a very good result. So key aspects: avoid contamination, the timing for media collection. What about the culture condition? Should we use a specific culture media, specific incubators, the volume of the drops? There has been different conditions reported in the different studies so far. And what is pretty clear is that there has been different volumes applied. We consider that with a smaller volume is working better, but what is very important is that to collect most of the culture, most of the drop in which the embryo has been cultured. You cannot have a drop of 20 microliters and then just take 10 and the other ones just discard. It's important to analyze all the volume and to be able to collect all the cell-free DNA released by the embryo. And regarding incubators, in our studies, we have compared many different benchtop incubators and with different culture media, and the results has been very inconsistent. The concordance rate in the validations that we have performed so far in Spain with the clinics doing clinical cases, we had a concordance rate of about 84%, 85%. If we are with the time lapse, we can have much better results. Here I put a slide that we presented in a meeting that is 86.5, but the truth is that with a time lapse incubator, we can have concordance rates close to 90%. So the combination of time lapse with non-invasive is giving us a very good concordance rate. And we think that is because of the shape of the incubators, of the dishes for the time lapse, because in the time lapse, when you have individual culture, you have the wells that are very narrow at the bottom. So the embryos are really sit at the very bottom in a reduced diameter, and all the DNA is going to be in this area. So it's very important when you are using a time lapse, just to be able to collect the culture media. It's a biggest volume, but the important thing is just to really aspirate the volume of the very bottom of the well, to be able to go really to the very bottom of the well. Then you can have really very good results with time lapse close to 90%. And then finally, regarding media collection. Regarding media collection, at the end of the process, we need to remove the blastocyst from the culture drop to transfer the embryo to the, if it is going to be a real case, to vitrify the embryo. So remove the embryo to do vitrification, to try to remove the blastocyst with not a very big capillary. So the idea is that you remove the blastocyst, try not to take too much volume when you are removing the blastocyst, and then aspirate the remaining volume of the drop with an automatic pipette, being very careful not to aspirate oil, and then to release the culture media in an empty PCR tube, properly autoclave or UV light exposed, and try very gentle to place all the volume at the bottom of the tube without bubbles. And after that, you can freeze at -20 overnight. These are basically the important things for media collection: to aspirate the most of the volume of the drop and not to aspirate a mineral oil. Then regarding the genetic lab, that is the second part and the second important player of the protocol, you can see here the list of publications with different sequencing methods based in Illumina, Thermo Fisher, and different amplification protocols. Most of them work very nicely with the culture media, except MDA protocols. The specifically based MDA protocols are not working with this DNA that is more fragmented in the culture media. So despite all the protocols work, you need to modify a little the protocols to increase the amount of cell-free DNA that is amplified. And we have experienced that. If we just apply the protocol of PGTA, the control drop, you can see that we have agarose gel representing the amount of DNA very, very, very pale. However, if we modify the protocol, then we can have higher concentrations as they can see in the agarose gel. So it's important also to modify the protocol to have the very good results. And finally, the diagnostic rules that we need to apply. And this is what I was talking about at the beginning. We cannot look with the same eyes the culture media than the way we are looking at the trophectoden biopsies. And this is a very nice explanation by the group of Catherine Rakowski, that they were working together with the Chinese colleagues to identify at which threshold for mosaicism they are having the better concordance when they were comparing the results with a full blastocyst. So they were testing for the right threshold to have the optimal false positive and false negative rates. And we don't want to have false negative rates, so we need to minimize the risk of false negative rates. And they identify that at 60%, then they have a lower false positive rate, not zero, but then they don't have false negative. So they identify this as a good threshold to call a culture media abnormal. So every aneuploidy below 60% should not be considered, on their opinion, and should not be
Any connection loss? Smriti, any connection
Maybe the
loss?
connection, yes, sir. Maybe we've lost the connection. But I can still see Madam.
I think so. We need to test. Somebody can put a chat that we are losing the connection. I will inform them. Yes, in between we have a connection loss. You can your audio is mute, Carmen. Yes.
okay. Can you see me
Okay.
now?
Now we
Apologies.
are hearing you. Yes, yes, perfect.
Yes. And can you see the presentation? It's because I don't know. Okay, I'm going to share a screen again. The connection stopped. Okay, we were here. Can you see?
Yes, ma'am. We can see now.
Okay, apologize for this. I don't know what happened. Okay, so we were talking that it's important to identify the right threshold to call culture media abnormal. And this is extremely important. Let me insist on that. Because if we observe deviation of the chromosome profiles at 20 and 30%, as we do for trophectoden biopsies, that we call these low mosaics, and we consider this abnormal, then we are going to discard many embryos. So it's very important to establish the right thresholds. And you will see how 3 independent different groups we have reached the same conclusion. So you have this work from Catherine Rakowski together with the Chinese colleagues. Then you have another publication from a Chinese team in which they were looking at the concordance rate with the trophectoden biopsy when they were establishing the threshold at 20%. So when they were calling abnormal everything above 20%, the concordance rate was 74%. But if they put the threshold to call an embryo abnormal at 50%, then the concordance rate increases to 87%. So you have seen Catherine Rakowski, 60, this team, 50%. And on our side, we identify also about 50%. So if we establish the threshold of about 50%, then we can have really a very good concordance rate with the inner cell mass, as we saw in our multi-center study with 1,300 samples. So this is important thing when to consider a chromosome abnormal when we are looking at the culture media. And we were applying this rationale. So we were looking at the different culture media in this multi-center study, many different results in the culture media, and we had the trophectoderm. So we were classifying the results of the culture media in 8 different boxes. So we have 8 different categories of results in the culture media according to the number of abnormal chromosomes, but also according to the type of anomaly, if it is an anomaly for the full chromosome or for a small part of the chromosome. If we have duplications or deletion. For example, if you see a report from a non-invasive in which they are saying you that an embryo, a culture media, has a lot of duplications, this is not real. These are artifacts of the technology because the fragments of the DNA are smaller. So we need to understand this very well. So a duplication is going to be really an artifact. And this is important when you see a report from the non-invasive PGTA. So according to this knowledge that we have now with this big number of studies with concordances, we can say with scientific knowledge which media has a better prognosis than the other ones, because we know which abnormalities are real and which ones can be artifacts. And according to this, we prioritize the embryos by the euploid score. So the embryos, the culture media category with the higher probability of corresponding to a euploid embryo, then we classify at the priority number 1, and so on, number 2, number 3, number 4. So the classification was always done according to the embryos that a patient has. So if we have 4 embryos, we do the prioritization according to which of these culture media we have the better prognosis for this embryo. So it's classified patient per patient. And this is the way in which most of the team are working, talking about prioritization. You have seen other groups saying that 3 categories like green, orange, or green, yellow, red, this kind of categorization saying lower risk of aneuploidy, intermediate risk of aneuploidy, and low risk of aneuploidy. These kind of prioritizations are the prioritizations that really make sense with this technology. And how to move this to a clinical application in your labs. As I mentioned, we are really concerned about how to implement the protocol in the lab. So with every lab we start to work with, it's very important to have a very close collaboration with the genetic lab. So it's very important that you talk very close to the genetic lab and to identify what is the right protocol that you should apply in your lab. And once everything has been established, it's important to do a validation, to identify that with the conditions that you have in your lab, applying the protocol, you have a very good concordance rate with the embryo. And you need to do a series of embryos in which you compare the results of the culture media with a trophectoderm biopsy, or the results of the culture media with a discarded blastocyst, for example, a triploid blastocyst. And if you reach concordance rate above 80%, you can think that your lab is doing properly. So these are just the results of the labs we have validated in Spain, from clinics in Spain and Europe. And this is very important because if your concordance rate is not good, then you are going to start to do the diagnosis of the cases, and you don't know if the information from the culture media is going to be real or not. So this is very critical step. And we also recommend, like, regularly, maybe once a year, to do a quality control of your lab, just checking again if the culture media results are similar to the embryo. So I think this is a good policy for each lab. And finally, what about the clinical results? We are doing all this work in the IVF lab. I know that the embryologists say, this is more work for us. We need to clean the embryos. We need to take these special measures. We know that it's more expensive than morphology because we need to do the genetic analysis. So is this all worthy? It will be worth it if we can increase our pregnancy rates. And what we have observed from clinics that are working in this technology, they have been comparing the results with a non-invasive in blue with cases with PGTA, and they have observed similar clinical pregnancy rates, similar ongoing pregnancy rates, and similar miscarriage rate. And in these cases, they were comparing also with the selection on Bayesian morphology. And what is very clear is that when you do a chromosomal analysis of the embryo and you transfer according to this chromosomal result, you are going to have better results. You can see how the ongoing pregnancy rates are about 12 points higher when you are doing a chromosomal analysis compared to the morphology. So we speculate that with the embrace, with the non-invasive PGTA, sorry, you can have the same results as PGTA if you are doing it properly, if you are diagnosing the DNA from the embryo and no DNA from other sources. So this is the clinical experience. What else should we do? We need to keep on learning about this. You know that we started PGTA, trophectoderm biopsy. We started PGTA more than 30 years ago. We started to be very active with trophectoderm biopsies about 8 years ago, and still we have learned a lot about mosaicism recently. So with the non-invasive, we are at the beginning. We are in the first 2 years in which some labs we are applying this. So we have learned a lot, but for sure we have room for improvement and we need to learn a lot. So we need to understand a little better what is the origin of the cell-free DNA. We need to identify maybe some automation that allow us to minimize the presence of contamination. We need to do clinical studies to identify patients and outcomes to see which are going to be the group of patients that are going to have the best outcomes. And we need to keep on learning about the algorithms that we need to apply for the genetic results of the culture media. So we have a tool that is working nicely so far, but I think that in 5 years' time, this is going to be even much better. And coupled with time lapse, I think it's going to be even better. I think that the secret of the future in many areas of medicine is integration of information. So is morphology bad? No, morphology is a good indication. So we know about the morphology is one source of information. Time lapse, another source of information. Genetic information, another source. Let's put all together and we will make something better. So I think this is going to be the future, but it's going to take time because for all artificial intelligence developments, we need hundreds of thousands of samples to have a good predictor, and this is going to take time. So this is what we think about the future. We are working in basic research, trying to label the DNA from the chromosomes and doing live imaging with Nicolas Placha lab, that they are really experts in this live imaging. And we are looking for the miracle of seeing a fragment of cell-free DNA just going outside. So we are trying to look at many embryos, labeling the nuclear material to try to identify the mechanism. So this is a collaboration with this team. There are a lot of investigations trying to identify the origin of the DNA in the culture media. Now we know a lot about that. We have contamination and DNA from the polar body and cumulus cells, but we also know that we have DNA from the inner cell mass and the trophectoderm. So this is good result. It looks like that we have DNA from both compartments, but more research is needed. And as I mentioned, we need to do randomized control studies to understand this. And there are at least 2 studies ongoing by different groups, including us. So thank you very much for your attention. And I always like to thank the team. We have been a lot of people working on this project during many years. And I would like to thank Carlos Simon, that was the one pushing us to go to this protocol. Thank you.
Thank you, madam. It was a wonderful talk. Thank you so much. We have taken some messages, take-home messages from you with 80% concordance means lab is working well. And keeping integration of information, which was your key word, taking us to a better future. Thank you so much, madam. And Abha ma'am, I would request you to say a few words as we are moving towards the end of the series today. Abha ma'am. Okay, thank you so much. Thank you so much, everybody.
No,
On,
I can ask Carmen, Dr. Carmen. You are rightly said that that is what we are also doing, something focusing more on time lapse parameter also. The artificial intelligence that automatically measurement of the lagging embryo or the T8 or KID score or other things. But I want to say something about that. When we have a what is the exact mosaic ratio which was observed when you are doing NPGS to NIPGS, the sample which is coming across the world to you?
Okay. It's difficult to explain everything related to mosaicism in the culture media, but I don't know if many of you are familiar with the NGS and the NGS profile. So when we are doing a trophoctogen biopsy, things are easier because we expect that in most of the embryos, 99% of the DNA that we have in the biopsy is from the embryo, right? So we can have contamination in a trophoctogen biopsy, yes, but it's really unusual. So if we have a very clear aneuploidy, it means that it's going to have 3 copies very clearly. It's going to be in the threshold of 3 copies. And in the same situation, if we would have had contamination, imagine 20% contamination, this threshold would have lowered to a profile suggestive of mosaicism. And this is not common in the trophoctogen. We don't worry about that. That's why we can call high mosaics, low mosaics, and so on. However, in the culture media, we know that we can have a lot of contamination, masking fully the results, but we can have subtle contamination. And this subtle contamination is not the best thing, but we can still give a diagnosis if we have subtle contamination. So this is the case. We have a very clear aneuploidy with showing that a chromosome is with 3 copies, but if we have subtle contamination, this is going to appear as a mosaic. Because so that's why we cannot give a very clear call of mosaic. If we are telling you in a culture media, this is like for chromosome 21, I have the level of mosaicism at 70%. Maybe what I'm telling you is that I have this percentage of contamination. That is not a real mosaic. That's why we decided not to call for contamination, also for mosaicism. Also, you know that now there is a big trend saying that even in trophoctogen biopsies, everything below 50% is giving us a very good result. So I think it's better related to the culture media not to think about mosaicism because of these 2 reasons. You cannot be 100% sure if this is a mosaic or is the presence of subtle contamination, and the trend that is coming now is just to consider about 50% the threshold to consider that an embryo has a good possibility to implant. That's why we don't pay attention to the mosaicism.
So do you want to work on metabolites over the NPGS, or it is not going to work? Because
Well,
previously we all people are focusing on the metabolites of the embryo, and then we left because we know that there is no any concordance regarding the euploidy status or the good quality. But now we are having a time lapse. Now we are having a NPGS, and would you believe in your just any thought process that this is the third one that we can add, or only AI is? Because AI is again a combination of TLM and the photography plus NPGS and plus metabolites, is it worth, or there will be no means it's a wastage of time to study on that?
Well, I can talk maybe about my experience. I know there are other teams working on that. We started also with metabolites as you. So Carlos was very interested in metabolites, I would say more than 15 years ago.
Yeah.
And we were so happy about metabolites that we also have developed a startup to try to develop this for metabolites, because at that time we were thinking this was the future. But the point is that we never found a correlation. And the point is that we have such a variety of different chromosomal abnormalities that can impact metabolism, that different aneuploidies for different chromosomes or different number of chromosomes are going to give us different results. So we were trying to focus in the trisomy 21, but not even with trisomy 21 compared to normal embryos, we observe a good pattern. Our thoughts are that metabolism really is very different depending on the chromosomal abnormality, but also is highly impacted of the different culture media, incubators, and transport is difficult, and preservation. So can we have indirect ways of identifying the metabolism? Then I think we should think and be back to the mitochondrial DNA that is giving us a kind of suggestion of how it is working. And let's think in other omics coming to the field. Let's think about transcriptomics, and let's think about methylome. We can have the risk also with transcriptomics and methylome to be affected by the culture conditions. It's very clear that DNA is the most robust molecule because it's not changing. Transcriptomics and metabolism and methylome can change with the conditions, but I think that the future maybe is integrating imaging, DNA, maybe RNA, maybe.
My last question, that are you believe in rerun of the embryo, those who are having a abnormal or something low mosaic? What is your experience on that? That if you rerun in your center, then it might come something mosaic, it's coming in normal or like that. What is about the percentage? Should we give the chance to the patient that after having a low mosaic, that we can give a chance that, okay, we can go for the rerun of the sample?
Okay, well, we don't have an IVF center. I can talk about the IVF clinics that work with us, that they have started to
But the samples are coming for rerun. Are you doing rerun of the samples or not? Because we are always insisting sometime when patient is only 3 embryo, and suppose all 3 are one is abnormal, 2 is low mosaic, or 1 is low mosaic, right? So, and 1 is normal but might be morphologically not good. So in that conditions, that if we rerun, then is it any advantage of rerun? What all some literature and some people are discussing, do you believe that rerun will make a sense? Any high resolutions or something, it make a sense in change of results?
I think that the first choice is going to be always transferring the euploid embryo. If you have a euploid embryo, and if it is an alive blastocyst, I mean, like a clear inner cell mass and not a very degraded trophectoderm, I think this is going to be always the first choice. But you can have always the consideration for the low mosaics. I could say that the most common answer from the patients are that they don't want to transfer a mosaic for chromosome 13, 18, and 21. So this is clear. For those chromosomes, the patients, they don't feel comfortable after receiving the genetic counseling. For other chromosomes, patients and clinicians are getting more and more comfortable little by little by transferring low mosaics, just the low. And it's a question of talking very clearly to the patient and starting to show the results. Last week, we have the PGDIS meeting in Paris. Many groups are showing their experience, and there is increasing evidence that with low mosaics, we can have healthy babies, but that the implantation is going to be a little lower than with haploid, and that the risk of miscarriage is going to be a little higher. and through amniocentesis, you are going to have a risk of having a confirmation of the mosaic in the amniocentesis in less than 1% of the cases. The risk is not high, very similar to regular population, but it's important just to bring the numbers to the patients. And I think that many cases we have a low mosaic, is a good blastocyst, and it's the last opportunity for the patient. So we need to put everything in context and to receive the proper genetic counseling.
Thank you, Smriti. You can conclude it. Thank you, Carmen.
A pleasure.
Thank you, Dr. Carmen. As I said before, it was a really wonderful talk from your side. And I have taken many messages, and so must have the rest of the viewers. And coming to the end of the session, I would also like to take an opportunity to thank the Indian Fertility Society for being the associated with Wings IVF to organize this session and this series. Also, I would like to thank the academic partner, Corona, for organizing such wonderful conclaves, which is definitely going to help us, the ones in the initial practices, and such things will take us to a brighter future. Thank you, everybody. Have a great evening. Thank you, Jay, sir. It is always wonderful to hear from you, sir, and I think it should be a never-ending session when you are teaching. So it was a wonderful session, and we'll be expecting Dr. Rubio in another series also, sir. So
Yes,
we'll be
sir.
welcoming Madam for that also.
She
Thank
will
you
be
so
coming
much.
with some new science. She is always used to,
Definitely.
habitual to coming with the new science. Thank you so much.
Definitely, sir.
Yeah.
Thank you, everybody. Thank you so much, sir. Thank you.
Bye-bye.
Bye. Wish you a
Thank
good
you.
evening.
Bye.
Yeah, bye.
Thank you. Thank you.